Assalamualaikum doctors, good afternoon. So today we have our 15th session of these recall based sessions, discussions, and we have a list of topic here. So let's have a look at the first topic, intussusception. So let me take you to MTP. Okay, so for this intussusception is a condition in which part of the bowel telescopes into another segment of bowel distal to it. So of course, we know very well the size of the bowel, especially small intestine, is approximately in meters. So it's very much long. So what is happening sometimes, some part of the distal bowel is actually going to telescope into another segment of bowel. It's going to intermingle in that one, and it can be caused by a polyp or hard stool or lymphoma, or can even have a viral origin. Most often, however, there is no clear etiology. So exactly we don't know why it is happening, but sometime maybe idiopathically, maybe we don't know, we don't know the reason, but some of the bowel is actually going to telescope into another segment. You know the exact physiology of telescope, right? When you're going to open telescope, so it's going to become, you know, longer and longer, and once you stack all the parts of the telescope, it's going to be very shorter. So just the same thing is happening in the bowel sometime, and that term here in the bowel will say it's intussusception. Most of the time it can be because of the hard stool, maybe because of lymphoma, maybe because of polyp, but that is not, you know, anything which you can say it's the most important cause of intussusception. No, we cannot say like that, but yeah, sometimes it may happen in this way. So now we have this one, current jelly. What is this one, current jelly? That's the presentation we will see here, like seen with Klebsiella pneumonia and the lungs as sputum, or as a stool in the setting of an intussusception. So most of the time when we see especially stool, so you can just imagine in these patients when they pass stool, because of this telescoping of the bowels, we will see some type of current jelly stool appearance, and this jelly is also appear as a sputum as far as lungs are concerned. So in Klebsiella pneumonia infection, if whenever there is a Klebsiella infection, we can see this sputum also just present like a jelly-like structure, and stool also present just like a jelly-like structure, and that jelly is called as current jelly. So whenever the term current jelly is written somewhere, just think about intussusception, where actually the bowels are actually going to telescope, you know, they are actually telescope into one another, means getting inside the one loop, and the other loop is going to stuck in that loop, and the other loop is going to stuck in another loop. So there will be a stacking of the loops just forming like a telescope. So this current jelly presentation is a typical presentation, is a typical term related to intussusception. Etiology will think about in the way that most of the time etiology we don't know, but we may think about any viral infection, we may think about this Klebsiella infection, we may think about any kind of hard stool, constipation, polyp history, lymphoma history. So these are some of the things where we can find this type of bowel presentation. Now here, intussusception present with colicky abdominal pain. Of course, bowel loops are actually going to telescope into each other. So the patient may present with colicky abdominal pain, bilious vomiting. We can see in these patients and current jelly stool. So of course, that's the presentation. Colicky abdominal pain, bilious vomiting. Why bilious vomiting? Sometimes the vomitus is green in color. So whenever the vomitus is green in color, we always think about biliary vomiting. That is called bilious vomiting. A right quadrant sausage shaped mass can be palpated. Now, this is again very important. You should know the exact shape of the mass. So if it's mentioned sausage shaped mass, think about intussusception. Whenever it's written olive mass, we'll always think about pyloric stenosis. So there are especially, you know, some mass presentation, some shapes of the mass, on the basis of, you know, we can have a clue that what can be the diagnosis or what can be the provisional diagnosis. So if you can appreciate in the right quadrant of the abdomen, there is sausage shaped mass, you can think about intussusception. Again, it's not hard and fast. You will see the presentation of your patient. If the patient is presenting with colicky pain, the patient has this current jelly stool, the patient is saying my stool is just like a jelly-like structure, or I have this green vomiting, green vomitus is there, then of course you can think about intussusception. How you're going to diagnose this one? Ultrasound. On the basis of ultrasound, that is going to consider as a best initial test and will show a donut sign or target sign. So if donut sign is there on ultrasound, that's a particular ultrasound structure, ultrasound shape by which you can easily determine this one, which is generated by concentric alternating ecogenic mucosa and submucosa band, because telescoping is there. So one band and the other band, you can easily differentiate the mucosa of one bowel loop to the submucosa of another bowel loop. So this is how the donut is going to form, and this donut sign is easily differentiable on ultrasound. We can also do barium enema, but barium enema is here both diagnostic and therapeutic as well. It's not only going to help you in making a diagnosis of intussusception, but also it can act as a therapeutic. Therapeutic means it's going to treat that disease as well, and therefore the most accurate test. So whenever they ask what about the most accurate test for intussusception, think about barium enema. And when they're saying what is the best initial test, we'll always go for ultrasound. So on ultrasound, you will find donut sign, and for on barium enema you will see especially that's not only going to diagnose, but it will also help, it will release the telescoping feature of the especially this bowel movement. Now however, it is contraindicated if the child has signs of peritonitis, shock, or perforation. Of course, whenever there is perforation or signs of peritonitis, or the shock is there in the baby, then in that condition we cannot give enema. There are certain conditions in which we should not do something or introduce something inside the body. Again, it's going to cause pain. If peritonitis is there, already the baby is already all the peritoneum is inflamed, we cannot introduce something below from the anus, because for barium enema you have to give enema that is going to pass through retrograde, and that can cause more pain to the patient. That's why we should avoid this condition. So how we are going to treat this intussusception patient who are presenting with this colicky abdominal pain, who are presenting this current stool? So fluid resuscitation and balancing of electrolytes. First of all, we need to have a equilibrium in the body, especially this electrolyte in equilibrium. So fluid resuscitation, if needed, are the most important initial step, followed by NGT, decompression of the nasogastric decompression of the bowel. So first, always think about, we have to maintain the electrolyte balance. So we will look for the values of potassium, calcium, and magnesium. If anyone is disturbed, we have to balance that one first, and then followed by nasogastric tubal decompression of the bowel. If there is a need of decompression of the bowel, we can go with that. But most of the time, only with the help of this electrolyte balancing and barium enema, which is considered to be the therapeutic one, it's going to release the bowel. Telescoping of this bowel can be released. So barium enema also acts as a curative therapy. The child must be carefully observed, as approximately 10% recur within 24 hours. If barium enema is not curative, then emergent surgical intervention is necessary to prevent bowel necrosis. Of course, we cannot leave the bowel in that telescoping position. We have to make sure that the bowel should be straight, and for that barium enema, if barium enema is not working or is not curative, although with the help of this barium enema the bowel can be straightened up, but if it's not, then of course we have to go for surgical option. Why we are opting for the surgical option? Because we always think that we may introduce necrosis in the bowel if we are going to keep or let the bowel be like in a telescoping position. It should not be in that position. It has to be straight. And what we can do, we can provide barium enema. If it's not working, then we have to go for surgical option. So let's have a look at the question. Here the question is saying, a 7-month-old baby presents in emergency department with irritability and intermittent crying, during which he pulls up his legs, followed by periods with no discomfort for the last 4 hours. The continuous crying was there. He had started to vomit just before his parent brought him. On examination, the child looked ill and lethargic, with a distended abdomen and a palpable mass in the right upper quadrant. Now, this baby who is having a mass in the right upper quadrant, right? Although it's not mentioned here, it's a sausage-shaped mass, but you can easily appreciate the mass in the right upper quadrant of the baby. The baby is having vomiting just before his parents brought him. The baby is crying because it's crying, and he pulls up his leg, followed by a period with no discomfort for the last 4 hours. Normally, those who are in the ages of like 7 months, 6 months, 4 months, we may think about colic pain, right? So you must have heard that whenever the baby is crying in the early ages, like up to 6 months, up to 8 months, 9 months, that baby mostly have this colic pain. So that colicky pain is there, vomiting is there, mass is appreciable. So what you can think, heart rate is okay, because in babies heart rate is usually high. Temperature is not there. Which of the following is the most likely diagnosis? So temperature is there. Temperature is 38.6 degree and respiratory rate is okay. Which of the following is the most likely diagnosis? Do you think it's a pancreatitis or appendicitis or gastroenteritis or intussusception? See, if it's a gastroenteritis, the baby must be having diarrhea as well. So there is no history of diarrhea mentioned here. Although we will always, in order to make a diagnosis of intussusception, we can have a diagnostic clue of this current jelly stool, but that's nothing mentioned here. Here only mentioned colicky abdominal pain, here only mentioned vomiting, here only mentioned palpable mass. So you have only 2-3 things in order to diagnose. So we have to rule out the answer choices and we have to choose the best one. So do you think it's a pancreatitis case? In the pancreatitis case, what do you think? In 7 months old baby, anyhow, pancreatitis is not common in very early ages. Plus, do you think the baby has this vomiting? He had started to vomit just before his parents. So if there is a history of vomiting, maybe sometime vomiting is there. And here also it's not mentioned because it's a recall. So we don't know whether the vomiting is bilious vomiting or what kind of vomiting is there. We cannot appreciate that much. Or do you think in the case of pancreatitis, are you going to feel a palpable mass in the right upper quadrant? Of course not. That is not going to be the presentation in the case of pancreatitis. And do you think appendicitis? For appendicitis, again, you will not going to appreciate any palpable mass in the right upper quadrant. So right upper quadrant, palpable mass does not comply with this pancreatitis, does not comply with appendicitis. Gastroenteritis presentation is not there because diarrhea, which is a basic symptom, is we are not going to have in this question. So most likely because of the palpable mass in the right upper quadrant, because of the colicky abdominal pain, because of the vomitus, we can think about intussusception. But there are certain things here in this question where you can see like current jelly stool, if it's mentioned, that is going to help you in making a diagnosis. Of course, that's a very good thing. And this palpable mass, if it's mentioned sausage shaped mass, that again is going to help you a lot. So of course, and this vomiting, if it's mentioned biliary vomiting or bilious vomiting, so that's again is going to help you clearly in making a definitive diagnosis of intussusception. And when you do ultrasound, on ultrasound, you will find donut sign, and that's why you are going to say you can make your definitive diagnosis. So for the next one, we have to go for the theory first. Next, we have pyloric stenosis. So for pyloric stenosis, they're saying a hypertrophic pyloric sphincter prevents proper passage of GI content from the stomach into the duodenum. So normally we have this sphincter, and what is the phenomena of this pyloric sphincter? It is there in between where you can see the GI content is passing from stomach into the duodenum. So that's the narrow portion of the stomach, which is called pylorus, and the start of the small intestine, that is called duodenum. So in between stomach and duodenum, we have this normal anatomical structure that is called pyloric sphincter. But whenever there is hypertrophy, means increase in the size of the cell of these pyloric sphincter occurs, then what will happen? It's going to cause this problem here in the way that this opening of stomach into the duodenum is going to be stenosed, and there will be a problem here in the passage of the food from the stomach into the duodenum. So what is the most common cause of this thing? Why this sphincter is actually become hypertrophied and preventing the entry of food from the stomach into the duodenum? We don't know exactly. That's idiopathic. So there can be many reasons by in which you can see in your patient that the patient may present with pyloric stenosis. So there is no definitive cause by which we can say, okay, this is the cause. That's why this sphincter is actually hypertrophied and it's going to narrow the passage in between stomach and the duodenum. Now, what is the presentation? Of course, whenever there is hypertrophy of the pylorus, what will happen is not commonly found at birth, but rather becomes most pronounced by the first month of life. So it's not congenital one. It's not like that the baby is going to born with this sphincter hypertrophy. No, after the birth of the baby, we can usually appreciate. It can present as late as 6 months after birth. So presentation is very important. Whenever you see any child in age ranges between 1 month to 6 months, you can think about this pyloric stenosis. Now, auscultation will reveal a suction splash, which is the sound of the stomach contents slapping into the pylorus like waves on a beach. Why? Because stomach is a wider portion, the fundus is too much wide, and the content has to go into the duodenum. Of course, if you consider the size of the stomach and if you consider the size of the duodenum it's very thin, of course, because this chyme has to come in the duodenum. Chyme is already the churn food, already the food which is broken down into pieces, already the enzymatic action has already done on that thing. So that is just like a liquid thing which is coming inside the duodenum. But of course, in the stomach, the whole food is there. That's the food has to be churned in the stomach, has to be, the whole digestion should take place in the stomach, especially when related to the protein part, the fat part, and the carbohydrate part. It's okay. The more and more digestion will take place in the duodenum, jejunum, ileum. But the process of the food, where you can see it's going to convert it into chyme, which is a very liquid, or you can say very soft and thin viscosity substance, that has to be taken place in the stomach. So think about this one. When there is obstruction in between the stomach and the duodenum, what will happen? A broad thing has to open into a very small thing, and again the passage is very small because the pylorus is hypertrophied, and this sphincter is getting narrowed and narrowed, and you will find a very small path exit for food content from stomach into the duodenum. So what will happen? Think about that. When the water has to go from a very broader portion to a narrow portion, then what will happen? The water has to exert so much force. It's going to, it's going to smash and crash with the walls of the stomach again and again, and it will find a very small path to enter into the duodenum. Think about, the stomach has a gate. That gate is called pyloric sphincter, and that gate is opening into the duodenum, and the gate is very small. So whenever the large amount of water is going to strike to that small gate just in order to pass away from that area, so there will be a suction and splash. There will be so much sound. Think about, the water is there. The water is there now. The water is striking from the walls of the pylorus just to get out from that area and being into the duodenum. So there will be a sound. There will be a sound, and that sound is called suction and splash, which is the sound of the stomach content slapping into the pylorus like waves on a beach. And that waves on a beach is actually, don't find a big path to cross. There's a very small path. Why the path is small? Because already the hypertrophy of the pylorus is there. Now, non-bilious projectile vomiting is the hallmark feature. So whenever you will see here non-bilious, that is not a green content, projectile vomiting. Of course, projectile vomiting. Why? Because that is going to be a very forceful vomiting. That's a hallmark feature of this one. Pyloric stenosis. Metabolic imbalance demonstrate a hypochloremic and hypokalemic metabolic alkalosis. So because of the vomiting, whenever there is vomiting, always think about the chloride will be lost in the vomiters, the potassium will be lost in the vomiters. As a result, the whole pH of the blood, you are going to see that is going to be an alkaline pH. There will be less acidic content. All the acidic content will be lost in the vomiting. Remaining, the pH of the body will become alkaline. So in the vomiters, because of the loss of the chlorine, because of the loss of the potassium, we will see less chlorine inside the blood. That term is called hypochloremia, and less potassium inside the blood. That is called hypokalemia. And why metabolic alkalosis? Because pH of the blood is going to be high. It should be more than 7.45. When the pH is on higher side, we can say it's alkaline. Alkalosis. When pH is on the lower side, less than 7.35, we can say it's acidosis. So whatever the pH in between 7.2, 7.35 to 7.45, that's the normal natural pH. If it's below 7.35, it is acidic. If it's more than 7.45, it's basic. So just think about this one. Whenever vomiting is there, the pH always going towards alkaline side, always become more than 7.45. Why? Because most of the acidic content is going to lose in the vomiters. So because hydrogen ion also is going to be lost, and this hydrogen ion is the one who is actually maintaining the buffer system, who is maintaining the pH of the blood. So H positive ion will make the pH more acidic. So here they are saying due to the vast loss of hydrogen ion in the vomiters. So if the hydrogen ion is going to be lost in the vomiters, the pH automatically goes towards alkaline side. Now the potassium loss also worsen from aldosterone release in response to hypovolemia. So of course, when someone vomits, then what will happen? The volume will be low. The blood volume will be low. And when the volume of the blood is low, the aldosterone activated. And once the aldosterone activates, that will cause the loss of potassium inside the urine. So you will find less potassium in the blood. So all this phenomena can cause less potassium in the blood, less chloride in the blood, and more pH of the blood. Now, aldosterone increases urinary excretion of potassium, because aldosterone is the one who will do what? Who will do actually more excretion of the potassium, and in turn, the sodium will be retained. So sodium amount will be high in the blood, but potassium will be lost. Why? Because aldosterone is functioning. And why aldosterone is functioning? Because of the hypovolemia. And why hypovolemia is there? because the patient just now had a vomiting, right? So because of the vomiting, the blood volume is low. Once the blood volume is low, aldosterone is activated. Once the aldosterone is activated, it's going to do what? It's going to excrete more and more potassium outside in the urine, and the sodium will be retained inside. So as a result, sodium will be more in the blood and potassium is going to last in the urine. So less potassium will be in the blood. The term is called hypokalemia. So you will find hypokalemia, especially this hypochloremia, chloride will be low, and alkalosis whenever there is vomiting. So these three things, especially as far as this electrolyte balance is concerned in the pyloric stenosis, plus non-biliary, this non-bilious projectile vomiting. These two major things are the major hallmarks in making a diagnosis of pyloric stenosis. This is the one non-bilious projectile vomiting, which is the hallmark, but you should also see hypochloremic, hypokalemic state of the body, especially alkaline side. Now, olive sign, that's again very important. Like in intussusception, we have just read that intussusception, the sausage mass is appreciable in the right upper quadrant. Whenever there is pyloric stenosis, you are going to see olive sign. Olive sign, which delineates a palpable mass, the size of an olive felt in the epigastric region, is highly associated with this children. So in this condition, so whenever you can appreciate a mass which is olive size mass inside, especially in the epigastric region, you can always think about this pyloric stenosis. So whenever it's mentioned olive mass, this pyloric stenosis should come in your mind. Whenever it says sausage shaped mass, intussusception should always come in your mind. So how you're going to diagnose these patients, those who are having pyloric stenosis? The best initial test is an abdominal ultrasound. We will always go for the sonography. We will always go for the abdominal ultrasound that will show a thickened pyloric sphincter, because we know the pathophysiology. The pathophysiology is there is hypertrophy of the pyloric sphincter. So when you do ultrasound, you can easily appreciate, okay, the walls of the pyloric sphincters are thickened. Now, the most accurate test in upper GI series, which will show 4 signs. Now, what are the, especially if we are considering upper GI series, we will do, and we will see some signs. And this upper GI series in the form of barium solo you can give, and you can perform endoscopy and you can easily see. So first sign is a string sign. String sign is thin column of barium leaking through the tightened muscle. Of course, when you do the barium follow through, when you enter the barium in the body and you will trace the barium, you will see the first sign is string sign, that the barium has to pass through the tightened muscle, and that tightened muscle is pyloric sphincter muscles, right? Then we can see shoulder sign, filling defect in the antrum due to prolapse of the muscle inward. So because of the prolapse of the muscle, especially all these muscles of the pyloric sphincter, which muscles they are going to form the pyloric sphincter, because of the prolapse of those muscles, we can see the antrum is actually not filling too much. So that sign is called as shoulder sign. So we can appreciate the shoulder sign here as well. Then we have this mushroom sign. Mushroom sign is hypertrophic. Am I audible? Guys, can you hear me?
Yes, yes, yes.
Okay, because no one is responding and some of them are leaving. I thought I'm not audible. Okay, so mushroom sign is hypertrophic pylorus against the duodenum. So you can see what is mushroom sign. This hypertrophy of the pylorus muscle, it can give. Okay, let me enter Dr. Asha. Hypertrophic pylorus against the duodenum. So duodenum, of course, and it's a small narrow tube, and you can see this hypertrophied pylorus. So that will give you a mushroom sign. Mushroom, the bigger portion is hypertrophic pylorus, and the smaller stalk is just like a duodenum. Then we have this railroad track sign, like axis mucosa and the pyloric lumen, resulting in 2 columns of barium. This pyloric lumen, in which the barium is going to be or retain too much, you can find barium in this way, that you can easily appreciate that there is 2 railroad track. Railroad track means, yes, doctor.
Please show us these science pictures.
Yeah, I will show you. I will show you. Just imagine and just familiarize yourself with the term, and then I'll show you. So this railroad track sign, axis mucosa and the pyloric lumen. In the lumen, there is too much mucosa because of the hypertrophy of the pylorus, and that result in 2 columns of barium. So when I have 2 columns of barium, it will just give you an appearance of railroad track. I will show you this one. So let me take you. That is report back.
You will type one, they all will come.
Okay. So let me show you this mushroom sign. For mushroom sign, it's very much clear, right? You can appreciate that this is the pylorus and this is the you can see this is inside the stomach portion, but here is the pylorus, and there is too much filling of the barium here, and this is the duodenum. So it's just like a mushroom cover and stalk of this mushroom. So this is mushroom sign. This is pylorus, and here, of course, the whole content of the stomach is going to be filled with barium. You can appreciate easily, and this is the duodenum. So this is mushroom sign. Here also you can appreciate mushroom sign. Let me show you the other one, rail track sign. I can see here. This one's double bubble sign. Maybe I should only write rail track. String sign. String is the first sign, if you can appreciate the first, but there are too much other things as well. Double track sign. See, this double track sign is actually that railroad track sign. And what is happening here, because of the hypertrophy of the pylorus, you can see barium is going to divide into two things. Like you can see the narrowing portion is here, then again barium is accumulated here and the barium is accumulated here. But it's not very much good. You have to see parallel two lines for this one. The string, here you can see string sign and shoulder sign. Let me take you this one. Here you can see three signs together. So this first one is a string sign. You can easily differentiate that this is all stomach and this is all is a very light string is there because of the stenosis. Can you appreciate this one? This string is only because of
Yes,
stenosis.
yes.
So this one is duodenum. Duodenum is filled with barium and the whole stomach is filled with barium. But this portion, which is actually the pyloric sphincter area, that is very streaked like. So that is string sign. And here you can imagine this one, the shoulder sign. Shoulder sign, why we are saying like shoulder sign, because again the filling of the whole stomach is there. The string is there, pyloric sphincter size, and then again this duodenum is here. So this one is too much broader area. So that broader area, they are actually pertaining that area to a shoulder site. So they are saying that this is just like a shoulder, the broad area, and this is a string sign together. And this one you can see it's a double track sign. Double track, like one track you can find here, one track you can find here, and in between there's a very small string, a very small showing this one area. That is a pyloric sphincter where there is too much narrowing. It should not be that much narrow, right? But think about like this one. So they are saying this is the area where we can appreciate the barium. This is the area we can appreciate barium. But here there is nothing in there. So it's just give you appearance of two tracks. One track is this one track is this one, separated with a string. So all of these, of course, are only one sphincter. So all of these
Dr. Hira, double bubble is also a sign of pyloric stenosis.
yes,
Please
double
show
bubble
me.
sign also.
I saw in my house job back many years back.
Okay. Double bubble sign is this one. See, it's very much clear here. This one, double bubble, or maybe this better see this one because this is hypertrophic pylori. Because of duodenal atresia, also we can find this double bubble. So think about what you are searching. Are you searching double bubble in duodenal atresia, or are you searching double bubble in hypertrophic pyloric stenosis? So this is the one where it's shrinking. Can you appreciate this two bubbles, this double, this two black areas? So these two black
Yes.
areas is showing what? They are showing that too much filling of this barium or too much filling of the fluid, because whenever the fluid is there, it will always appear anechoic in ultrasound. So when you do the ultrasound, you will find anechoic area. Anechoic area means the area which is having too much fluid inside. That area will present on ultrasound as an anechoic area, the black area, so that you can easily differentiate. That's a double bubble. But this double bubble sign is also very much common in duodenal atresia as well. So think about the question, whether the question is asking duodenal atresia or the question is asking pyloric stenosis.
This bubble becomes because of the
Because of the filling of the fluid. Yeah, because of the because of the accumulation of fluid, accumulation of this kind into the stomach, and accumulation of kind into the duodenum. So two sides are quite visible, but inside, because of the pyloric stenosis, that area is whitened. That area is not going to show anything. So you will find all the chyle collection in the stomach and all the chyle collection in duodenum. The middle part is going to show no area. You will see all the echogenic part in the middle. So you can easily appreciate this side is black and the other side is black, and in between there is nothing, because stenosis was there. So that's why it appears like double bubble.
Okay, thank you.
So here what we are going to do for the treatment part, the replace lost volume with IV fluid. So whatever the volume is lost in the form of vomiting, you have to replace that one. Replace lost electrolytes. So potassium is less, chloride is less. We have to maintain all the electrolyte balance. Specifically, potassium as the chloride dynamic is crucial. Nasogastric tube must be used to decompress the bowel. So always for the decompression, when we want to release the pressure of the gut, we can always introduce nasogastric tube that is going to release the pressure of the gut. And if no one is going to cure, then the last resort we have the surgery. So what we can do, we can create a myotomy, like we can just create a mouth opening. We will dilate that sphincter. We want to increase the diameter of that pyloric stenosis area. So we can go for surgical myotomy. So let's have a look at the questions. Here the question is saying a 5-week-old infant brought to the clinic. Now, age of the child is very important, because we have already seen this one, that most of the children who are in the ages between 1 month to 5 months or 6 months, they are actually presenting with this pyloric stenosis. Although it's not a congenital one, but it should be in between 1 month to 6 months. So a 5-week-old infant, but it's not like that 1 month. So it should be 1 month, like 5 weeks is more than 1 month, right? So a 5-week-old infant brought to the clinic with 3-week history of intermittent vomiting. So vomiting is there. After vomiting, the infant becomes very hungry and wants to feed again. Now, physical examination shows no alterations apart from a 2.5 kg weight loss. So history of weight loss is there. That is very important. Physical examination shows no. Now, the test result shows sodium 147. So sodium is high. Potassium 2.9, potassium is low. This is the normal range 3.5 to 5.1. So potassium is low, bicarb is okay, on little higher side. Chloride is low. So whenever there is hypochloremia, like chloride is less, hypokalemia, potassium is less. And in terms of potassium, of course, because of the aldosterone, sodium is going to be retained more inside the blood. You will see hypernatremia, and vomiting history is there. So which of the following is the most likely diagnosis? What do you think? It's a gastric volvulus, or it's a cyclic vomiting syndrome? Or do you think it's a hypertrophic pyloric stenosis, or it's intestinal malrotation with the volvulus? So we cannot say anything related to what? We cannot say anything related to volvulus here. We will do the volvulus later on. You can see it's a midgut. We will see it later. But right now, you just think about here. It has based on the presentation, based on the symptoms, vomiting, and based on the lab results, you can easily say the diagnosis. If it's there, like signs of barium studies are there, that would really help you in making a diagnosis. But of course, those signs are not here. But the presentation is very much common. Intermittent vomiting is there. The baby is hungry after feeding. The baby is showing the intermittent vomiting. The baby is showing all the electrolyte imbalancing, which will give you a clue of this one. So do you think it's a cyclic vomiting syndrome? Cyclic vomiting, if cyclic vomiting syndrome is there, in most of the time, it's not a true diagnosis. But whenever it's there, it's not going to show much changes in the body electrolytes. So that is only a clue where you can differentiate with this cyclic vomiting syndrome and the the vomiting, which is the non-bilious vomiting and the projectile vomiting based on pyloric stenosis. In pyloric stenosis, you will always find electrolyte imbalance. So it's a case of hypertrophic pyloric stenosis. Why? Based on the presentation, vomiting, and based on the lab results. Plus, if signs are there, that will definitely give you a clue making a diagnosis. Now this one. They're saying a 6-week-old infant begins to exhibit forceful vomiting. See, so the projectile vomiting is there after each meal. So after having each meal, there is a vomiting. It means that intermittent vomiting, continuous vomiting. After each week, the infant was born at form to a 23-year-old primary gravida whose pregnancy was uncomplicated and ended with a normal vaginal delivery. No congenital anomalies are noted upon examination. So a part of that, everything is okay. But only the thing is that whenever the baby feeds, what happened? He's going to vomit, and that vomit is actually a projectile vomiting. So whenever it says something like this, so here there is nothing, no investigation, no findings, nothing. So which of the following is the most likely diagnosis? Do you think it's a congenital Deuterophysia or necrotizing enterocolitis? Necrotizing enterocolitis is a very much infectious disease. The baby cannot only present with the forceful vomiting, the baby has to be in septicemic state in order to make a diagnosis of this one. Hirschsprung disease or pyloric stenosis. Hirschsprung disease we have already covered before. Of course, in order to make a diagnosis, we have to have clear-cut investigations and lab reports with us. Now, the only thing left here is congenital duodenal atresia and pyloric stenosis. So based on the presentation, you can think about duodenal atresia, but duodenal atresia is very much appreciable whenever the baby is intrauterine. The baby is not yet delivered, but on anomaly scan on ultrasound, you can easily differentiate that duodenal atresia is there in the baby, unborn baby or not. But when it's mentioned that no congenital anomalies are noted, then most likely is a pyloric stenosis, because pyloric stenosis is the one which is normally not detectable on anomaly scan. Like once the mother was pregnant, you cannot appreciate pyloric stenosis in undelivered child, but you can appreciate duodenal atresia in undelivered child. So that is the only difference here, because based on the presentation. Otherwise, of course, there are lots of other things which are very common in pyloric stenosis. Say, for example, lab results and especially the signs, all the radiological signs. So here the answer is
Dr. Sir,
yes, sir.
how to differentiate from necrotizing enterocolitis?
Necrotizing enterocolitis is a very much infectious state of a body in which the baby should be in septicemia. There should be a history of infection, and the baby will not be looking normal. The baby will be lethargic. The baby is in septic shock state. So here it's nothing like that. And here only the baby whenever feeds only vomits. That's the only thing here. Otherwise the baby is perfectly doing fine. The baby is not lethargic, it's not ill looking, there is no failure to thrive. But in enterocolitis, that's a very much infectious disease. The baby must be having too much diarrhea, severely dehydrated, WBC count will be too much raised, the baby will be showing this fever and all symptoms, all inflammatory symptoms will be there, right? All the signs of infection are easily appreciable. So that's a very, very, very much ill child. You can easily differentiate that child with this pyloric stenosis child, of course.
Okay, thank you.
All right, now this question. A 2-week-old infant present with projectile non-bilious vomiting. So whenever these projectile non-bilious vomiting word is there, you will always think about pyloric stenosis. That frequently contains dotted milk. After vomiting, the child still seems to be hungry. That is again a sign. Once the child feed, it will vomit and then it will start, feeling hungry. So you have to feed him again, and then again he will do the vomiting, and then he will again become hungry. On examination, there is mild dehydration. Of course, vomiting is intermittent, so baby must be little dehydrated. A firm, non-tender, and mobile, hard 1 to 2 centimeter diameter mass is palpable in the right abdominal quadrant and at the lateral edge of the rectus abdominis. So now the mass is palpable. If they have mentioned olive mass, that will definitely, help in the making a diagnosis of this one. But the doctor clearly said that there was nothing mentioned like olive. But it's okay if olive is not mentioned. They are only mentioned that a very small mass, 1 to 2 centimeter. So think about the size of the olive, 1 to 2 centimeter. So that's another clue, synonymatic clue for you. Now heart rate is Okay, respiratory rate, temperature is also okay. Abdominal X-ray sign, double bubble sign. Now, so no, sorry, abdominal X-ray single bubble sign. Which one of the following is the most likely cause? Now here it's showing single bubble sign. There are no two bubbles you can appreciate. So do you think it's a gastroenteritis? You can see it's a pyloric stenosis, the Reese syndrome, it's a gastric mucosal atrophy. So this again is a very important clue. We usually find double bubble sign, but whenever there is pyloric stenosis, which is just started, because this baby is just a 2-week old baby. 2-week old baby, it has, it's just less than 1 month. So maybe after 2-3 weeks, after 4 weeks, or within 6 months, this baby is going to develop too much hypertrophy of the pyloric sphincter, and there will be two double bubble sign will be easily appreciable on X-ray. As this baby is just 2-week old baby, this baby has pyloric stenosis, but the hypertrophy is not very much. That's why on X-ray it's just showing single bubble sign. It means that the stenosis has just started, but it's not very much developed yet because he is just 2 weeks old. And in order to make a diagnosis of his exact pyloric stenosis, we will see the major symptoms usually appear after 1 month, after 4 weeks, till 6 months, where the hypertrophy will become very extensive. And because of the hypertrophy, we can easily differentiate two bubbles. But as here the baby's age is small, he's just 2 weeks old, but he is presenting with the vomiting. It means that the pyloric stenosis has already started, but it's just the beginning of the pyloric stenosis. That's why it's not very much visible on the X-ray as well. We can only find one bubble sign, not two bubble sign. But later on, maybe after 2 weeks, 3 weeks, if the baby is like that, the baby can show double bubble sign. But right now, he's showing only single sign. So do you think it's a gastroenteritis? Of course, in making a diagnosis of gastroenteritis, diarrhea should be there, which is not here. Reese syndrome is a congenital syndrome that is detectable on an ambly scan. Of course, here is nothing is mentioned like that. Gastric mucosal atrophy, it's not complying at all. Atrophy is not the part here. We are not discussing anything about. And based on biopsy, you can only say atrophy and something like that. Without biopsy, you cannot say anything like that. But pyloric stenosis, of course, is the one which has a clear clinical diagnosis based on the projectile vomiting, based on the thing that the baby is feeling hungry, and based on the thing that the mass is palpable. So the baby is actually developing this hypertrophy of the pyloric stenosis. But as the baby's age is very, very low, like only 2 weeks, it will take some more time to fully develop this double bubble sign. Based on that, you are going to choose pyloric stenosis. Okay, now this one. A 4-week-old infant is brought to the clinic with progressive projectile non-bilious vomiting. Again, 4-week projectile non-bilious vomiting. The pyloric stenosis should come in your mind. Now, palpable olive in right upper quadrant. Now they have clearly mentioned olive mass. So olive mass is mentioned, or the size is like 1 to 2 centimeters mentioned. Think about only about this pyloric stenosis. Which of the following is the most appropriate? So now they are not asking you about the diagnosis. They are asking you what you're going to do. The best initial one. Remember, their best initial one is ultrasound. So we'll go for sonography. Ultrasound, sonography. Ultrasound is the best initial one, and for the most accurate one, we have this barium studies. So sonography is the one. Okay, now for this one, we have to go for the theory first. And theory is Midgut Volvulus. Okay, 66. Okay, what do we mean by volvulus? A volvulus is a bowel obstruction in which a loop of bowel has twisted on itself abnormally. It's not like just like intussusception. What is happening in intussusception? In intussusception, there is telescoping of bowel segments upon one another. But here, that's only one loop of bowel which is actually twisted around itself. It's not like that two loops, they are getting twisted to each other. No, it's the one loop which actually becomes twisted on itself. The same bowel is going to twist around. So that is known as volvulus. And in children, volvulus occur in the midgut, with the majority being in the ileum. So that's very much common in the children. And again, it's mostly happening at the level of the midgut. And embryologically also, when this digestive system is actually forming, there is a physiological or embryological volvulus is there. where the intestine has to take a 270-degree turn and has to twist around itself. But that's the embryological volvulus that has to be, of course, that's embryological one. That's only during the formation of the intestine, and it's called a embryological volvulus. But later on, it will become, of course, normal. It's not a pathological one, but this one is, of course, pathological one because this is occurring after delivery, and mostly at the level of the midgut in children, we have seen this condition. So what is the presentation of this one? The signs are non-specific and including vomiting. So the baby may present with vomiting, colic abdominal pain may be there. Multiple air fluid levels can be seen. Why multiple air fluid levels? Because twisting is there. So the shuffling of the gas will be there, and shuffling of the gas on X-rays, on barium studies will be presenting as multiple fluid levels. That is called gas inside the intestine. And on upper GI series, a bird beak appearance is typically seen at the site of rotation. Of course, wherever the rotation takes place, twisting around itself takes place, there you can see bird beak. So this bird beak is why the bird beak is there, because this part is actually twisted on itself, and it will give you appearance of a very small, very small, thin streak line. That is why it's called as a bird beak. A sign seen during acute episode of volvulus, that is malrotated segment. So what you are going to do, you will do the surgical endoscopic untwisting. You need to untwist that area. Of course, that is emergently needed. So we can go for surgical option. We can perform the endoscopy, and maybe during endoscopy, if you are able to untwist the bowel loop, that's okay. But if you think it's difficult, go for surgical option. Go for an open laparotomy. Bowel, why? Because if you just leave like that, then what will happen? There will be bowel necrosis with perforation, can lead to life-threatening sepsis. Of course, once the bowel is necrosed and the content is coming out, then what will happen? There will be a sepsis, life-threatening sepsis. So the best initial therapy is endoscopic decompression. With the help of endoscope, if you be able to untwist the segment, and the most effective therapy, and if the endoscopy fails, is surgical decompression. Then only we can go for surgery. So we'll try with the endoscope first. If it's possible, we will be able to untwist, well and good. If not, then go for surgical, direct surgery, open laparotomy. So let's have a look at the question. Here the question is saying a 4-day-old infant is seen by pediatrician in the newborn nursery for bilious vomiting and abdominal distension. So there is distension, there is bilious vomiting. The child is just 4-day-old. The newborn has been feeding poorly and is difficult to calm. So feeding is also not proper there, and it's very difficult to calm. The baby is in pain, colicky pain. The newborn passed meconium shortly after birth and has passed several seedy yellow stools each day since. So 4 days history is there, and you can see that this stool formation is also not proper. We will find some seedy yellowish spots on the stool. The physical examination confirm abdominal distension. So here there is clear examination. When the doctor has performed the physical examination with the hands, he can easily confirm that there is too much distension, abdominal distension. Now, which of the following is the most likely diagnosis? So based only on the basis of history and physical examination, like on the basis of sign and symptoms, if we are considering that vomiting is there, colicky pain is there, abdomen is distended. So what do you think? What should be the provisional diagnosis here? Do you think it's an allergic reaction to formula? If there is allergic reaction to formula, then what will happen? The baby should not be having this meconium and should not be having yellow stools. The baby should be having severe diarrhea if there is, any acute reaction with the formula feed. And do
Baby
you
must
think
be having a rash around her mouth.
yes, that is also one of the symptoms. And then what about this meconium ileus? If there is meconium ileus, there will be no meconium. There will be no passage of the meconium at all. You cannot find any kind of stool passing. But here, of course, he's saying every day the baby is passing stool, but that is seedling appearance, not properly digested one. And then the Hirschsprung disease, of course, that's an autoimmune disease. We cannot always make the diagnosis without having the lab investigation in front of us. We cannot say anything like that. So that's the only thing. But again, it should
He's already passed
this is a,
school.
yeah, this is a broken recall. So it should not be, they should not be asking which of the following is the most likely diagnosis, because only on the basis of this one you cannot appreciate. You have to go for studies option. You have to go for the barium studies, and you have to see whether there is really a bird beak sign of this volvulus is there or not. But anyhow, based on the presentation, because the rest of the choices are totally, we can exclude them on the basis of presentation. So based on the history of vomiting, based on the abdominal distension, based on the physical examination that the abdomen is distended, we can go for midgut volvulus. Only because of basis of the history, clinical examination, clinical history, symptoms, and physical examination. But of course, when you have this barium studies with you, you can appreciate the bird beak appearance is there, and that bird beak is actually showing you the volvulus end portion, the twisted end portion is visible. You can say, yeah, it's a definitive diagnosis. So it's just like most likely diagnosis, but it's not a definitive one. For the definitive one, you have to have studies with you.
Doctor,
For the next one, yes,
for the GI studies, we always give from anus, or we can give it through mouth as well.
no, if they're saying barium with endoscopy, so during endoscopy you can give barium. That will be a barium follow through mouth. But most of the time in children, when we want to see the distal bowel portion, we usually give enema, like from the anus. Yeah, but here it's during endoscopy you can give through mouth.
Okay.
For the next one, we have to go for the theory. So here we have next one, that is marasmus. Question is missing here. So marasmus we will do in the next class because the question is actually missing here. So let me take you to another topic, another one, and that is organophosphate poisoning. This is not very much, of course, it's not very much in detail in MPB. So I'll take you to Ambos here. So this is organophosphate poisoning. Now this organophosphate, usually when the child is prone towards getting the infection from insecticidal spray, any mosquito killer spray or any cockroach killer spray we have in our at home especially. So if the baby is allergic to that one, or if the baby suddenly inhaled that in too much quantity, then we have a chance of having this organophosphate poisoning in the babies or in any adults as well. So an organophosphorus compound, an irreversible acetylcholinesterase inhibitor. So what is actually here, especially related to this organophosphate, that these organophosphate are just act like as irreversible acetylcholinesterase inhibitor. This acetylcholinesterase is the one which is going to convert the acetylcholine into its active form, and inhibitor is the one which is going to actually inhibit the whole process. That's why we don't have in much quantity of this acetylcholine. And acetylcholine is one of the neurotransmitter which is responsible for so many actions, for so many motor activities. So that's why you will find very much different, very much unappreciable motor activities in these patients who are just having this poisoning of this organophosphate. So primarily, of course, because of the insecticidal spray, the patient can have this one. So absorbed through the skin, respiratory system, or GI. So anything, this one, maybe they have ingested this one, or maybe they just inhaled this one, or maybe the spray is there on their skin. So there are so many routes through which this organophosphate poisoning can occur. And irreversible inhibition of acetylcholinesterase means that there will be too much acetylcholine levels, because irreversible inhibition of acetylcholine esterase. Now this one organophosphate is actually act like an inhibitor. So the one who is acting like an inhibitor is going to inhibit the process. So now whenever there is a inhibition of a process, what will happen? There will be too much quantity of acetylcholine in the body. So we will see there will be too much quantity of acetylcholine levels in the body, those who are having the poisoning of this one. And based on this, because acetylcholine is the one which is the main neurotransmitter for all the motor activities, and what we will see, there will be activation of muscarinic and nicotinic acetylcholine receptors. And whenever there is activation of these receptors, we will see lots of parasympathetic activity in the body. So what are the things? We can see acute cholinergic crisis. Why acute cholinergic crisis? Because of the too much level of acetylcholine. Why there is too much level of acetylcholine? Because this organophosphate is the one who is going to inhibit the action of acetylcholine esterase, which is an enzyme which is responsible for the metabolism of acetylcholine. So if the acetylcholine is not going to metabolize because of the inhibition of this organophosphate, there will be too much level of acetylcholine. And because of the too much level of acetylcholine in the body, we will see cholinergic crisis in the body. And that crisis can bring paralysis to the body. because that's the only one which is controlling the all motor activity. So what we will see, the patient can become suddenly paralyzed because of this organophosphate, because of this heavy acetylcholinesterase, heavy acetylcholine levels in the body. Then parathion has a garlic-like or petrol-like odor. This parathion, let me show you this one. Parathion is actually the component of this organophosphate. It has parathion or E605. So that's the content of this one. They're telling you that this parathion, the one who is infected with organophosphate, they have a just petrol-like odor and garlic-like odor. So once you just smell the breath of these patients, you can smell that the breath is coming just like garlic-like or petrol-like. So you can have a clue with the breath of the patient that this patient might have a poisoning of organophosphate. Then sarin is odorless and tasteless. That's again the component of this one. Now parathion may cause blue colored saliva and mucosa. So if you check the buccal cavity, oral cavity, you can see blue colored saliva in these patients. So that's again is going to give you a clue. If the patient is presenting with you having this blue colored saliva, you can think about organophosphate poisoning. On GI, of course, on cardiovascular, the patient can be hypertensive, heartbeat will be low. On GI, you can see diarrhea, vomiting, and abdominal pain can be there. Uncontrolled urination, increased sweating, increased salivation. Why increased sweating, increased salivation? That's the phenomena which is actually happening because of acetylcholine. So here there is too much acetylcholine. So think about the acetylcholine functions, and you can see all the functions will be exaggerated in this body. So acetylcholine is the one who is going to maintain the sweating and salivation every process. So of course, all the parasympathetic activity are under the cover of acetylcholine. So all those activities will be increased. So we will see more sweating, more salivation. Bronchospasm can be there in CNS. The patient can present with tremors, seizures, possible coma can be there. But of course, that's a later sign. But early you can see tremors, and later you can see seizures and of course coma. Musculoskeletal, you will see too much fasciculation, weakness, spasm, paralysis. So paralysis is the one because of the increased activation of acetylcholine. So think about the person, or think about the patient who's presenting with you having the features of paralysis, tremors is there, too much salivation, sweating is there. When you check the buccal cavity, this bluish mucosa is there. And of course, you will see lacrimation, bronchoconstriction can be there. So too much signs of highly activation of acetylcholine is there in the patient. You can think about organophosphate poisoning. So chronic low dose exposure, chronic organophosphate means slowly if the patient is having this one, then the patient may present with fatigue, depression, impaired memory, extrapyramidal symptoms, peripheral neuropathy. But that is the one where, like, the one who is actually living in the area where the insecticidal spray is mostly, like in the farmers, they used to give this insecticidal spray in the farms. And what will happen? They are the chronic chronic suspect of this organophosphate. But most likely we use the patient who usually present in the emergency department has the acute attack of this organophosphate poisoning, not the chronic one. Anyhow, how you're going to manage these patients? You have to decontaminate, remove the clothes and wash the skin, because the insecticidal spray must be on the skin, must be on the clothes. So you have to remove them first, secure the airway, oxygen, provided if there is less oxygen, you'll go for the ECG checking of the bradycardia and all these things. Measurement of the erythrocyte cholinesterase activity, you will check the level of acetylcholine in the body. And medication, memorize this one because that's the most important thing which we need to memorize as far as our MCQs are concerned. You should know the antidote of this organophosphate poisoning. So antidote is atropine. Atropine is the one who is going to reverse the function of acetylcholine. Or you can give oximes also, like pralidozyme or this obidozyme, but most likely you will give atropine. So this oximes, what they're going to do, they will regenerate the acetylcholinesterase enzyme that is going to metabolize the acetylcholine and function peripherally on both muscular and nicotinic receptors should be administered of the atropine. So first you have to give atropine and then only you can give oximes, because atropine is directly going to antagonize the effect of acetylcholine, and oxime is actually going to initiate acetylcholine esterase. Acetylcholine esterase is the enzyme which is going to metabolize acetylcholine. So you have two functions. Either you can directly go and inhibit acetylcholine, or you go and stimulate the one who is going to metabolize acetylcholine. So if you give atropine, that is directly going to antagonize the effect of acetylcholine. And if you give oximes, Secondly, you will give enzyme. The first one you will give atropine. So once you give enzymes are actually going to stimulate the acetylcholinesterase, which in turn metabolize the acetylcholine. So that is the second way effect, good effect. Then benzodiazepines, of course, if the patient is presenting with seizures or tremors or paralysis, you can give them benzodiazepine. That's a symptom for the symptomatic control. But the most important drug which you are going to memorize here is atropine. Atropine, which is going to directly antagonize the effect of acetylcholine. So let's have a look at the question. Here the question is saying that a 12-year-old patient present to the clinic with diarrhea on vomiting, meiosis, constriction of the iris muscle, eyes muscle. You can see a constriction there, bronchoconstriction, sweating, excessive salivation. See, diarrhea, vomiting, bronchoconstriction, sweating, excessive, they are all because of acetylcholine. On examination, the breath has a garlic odor. So garlic odor, you remember whenever there is garlic odor, which one is actually the one who's the component of this one? Garlic odor. There are two components, parathione and serine. Parathione is the one, if it's there in the organophosphate poison, insecticidal spray, that is going to produce this garlic-like smell. So you will always think about organophosphate poisoning based on the garlic odor, based on all the acetylcholine actions like excessive salivation, sweating, vomiting, bronchoconstriction. These are all the effects of because of increased amount of acetylcholine in the body, because this shows that the body is having cholinergic crisis. So which of the following is the most likely diagnosis? It's a clear case of organophosphate poisoning. And he's just a 12-year-old boy. So he must have exposed with this insecticidal spray. Okay, for the next one, we have to go for the theory first. Infantile botulism. Let me take you to Ambus because it's not there in MTB. Infantile botulism or beriberi, which is the one. Sorry, I left the beriberi. So first we will cover the beriberi. So for beriberi, always think about there is a deficiency of thiamine. Thiamine is one of the essential amino acid that has to be there in the body. So if this thiamine is actually deficient, and that's all because of the deficiency of this vitamin B1. So
excuse me, Dr. Hira, I can't see the screen. Please share it again.
Okay.
Can't see it.
One minute. Now can you see the screen?
Yeah, thank you.
So always think about whenever there is vitamin B1, the another name of vitamin B1 is thiamine, which is an essential amino acid. So if this thiamine is deficient, that will actually cause a disease called beriberi. So always think about whenever it says the condition beriberi, it's all because of the deficiency of the vitamin B1. And this vitamin B1, we will see here in this beriberi, inadequate thiamine uptake due to malnutrition, heavy drinking, or increased demand, for example, hypothyroidism, pregnancy. Now, what is happening here? If the this vitamin B1 is deficient, that is called thiamine. Thiamine is deficient. It can cause malnutrition because thiamine is an essential amino acid as well, and these amino acids are necessary in making the protein. Of course, protein is the building block of our body. So, you know, right from the hairs until bones, everything is made up of protein. So think about that one. If someone who is deficient in protein, then what will happen? There will be malnutrition. Or they are saying due to malnutrition, or maybe if there is too much history of alcohol intake, which is normally not occurring here, but of course we have to know this one because we are talking about the whole worldwide scenarios. So maybe those who are alcoholic alcoholics, you will also see them in those patients that this thiamine is deficient. Or increased demand. For example, if the patient is the patient of hypothyroidism, in that patient, the patient metabolism is actually quite disturbed, and the thiamine can also be deficient in those patients, those who are having hypothyroid or pregnancy. So these are the normal body conditions where you can see thiamine deficiency, and these are the abnormal conditions where you can see thiamine deficiency. So what will happen there in beriberi? There are two types of beriberi. One is called dry and one is called wet. In dry beriberi, you will see symmetrical peripheral neuropathy. There are the signs signs of sensory and motor dysfunction. You will see some muscle wasting here, paralysis can be there, there will be confusion. So in dry beriberi, always think about sensory and motor dysfunctioning. But in wet beriberi, you will see cardiomegaly, you will see edema. Why it's called wet? Because there will be too much fluid in the body because proteins are deficient. So whenever proteins are deficient, protein is the one who is actually maintaining the oncotic pressure. So we have just read this in nephrotic syndrome as well. If protein is deficient, albumin is deficient, then what will happen? There will be too much edema of the body all over in the body. Why? Because protein is the one who is actually holding the water inside and maintaining the exact level of intracellular and extracellular fluid volume. But what will happen if there is deficiency of protein? No one is there to control this intra and extracellular fluid compartments, and there will be too much fluid extra outside. You get that in the form of edema, we can say. So you will see edema here in these patients, and high, of course, if there is too much edema, the heart has to work a lot. So you will find high output cardiac failure in this patient. So this is called wet beriberi. Now, there is also one which is quite appreciable in infants, especially up to 1 year of age of child, that is called infantile beriberi. There is as such no term, but if it's especially happening in the babies, we usually say it's an infantile beriberi. And here also the baby can present with all the signs of cardiomegaly, tachycardia. You can see aseptic meningitis like vomiting and seizures. The presentation is just like this one. The baby is having vomiting. The baby may develop this dry beriberi symptom, that is seizures, physical and especially sensory and motor disturbances there in the baby in the form of seizures. The baby may be cyanosed, may be presenting with vomiting, tachycardia is there, cardiomegaly is there. So if it's a typical symptoms are there, and when you investigate, you will find low levels of thiamine in the body of the babies, you can say this is infantile botulism, infantile beriberi. Now, this Wernicke's encephalopathy is a very much common complication, especially occurring in alcoholics. So whenever the alcoholic come to you and he is having the signs where he's confused and maybe he is going to go in coma as well. So in that particular state, we should always give thiamine to our patients, especially to alcoholics, because that's most likely because of excessive alcohol intake. Those alcoholics are actually deficient in thiamine and they may present with this encephalopathy. So always remember, whenever the patient who is alcoholic coming to you in confused state, and when you inquire, when you do the examination, you find the encephalopathy in those patients, you have to give thiamine at once, because these patients ultimately have thiamine deficiency. That's why Wernicke's encephalopathy is developed in them, and that's one of the major complications of thiamine deficiency in alcoholics, especially in alcoholics. Then we have this Lee syndrome as well. This is again one of the complications. And in Lee syndrome, there is mitochondrial myopathy that typically manifests in infancy with psychomotor delay. So because of the thiamine deficiency, because of the protein deficiency, we will see the mitochondria is actually not performing well. And because of the mitochondria is the main energy provider to the body. So you will find too many diseases. Just the mitochondria are not responsible for creating ATPs, and ATP is the one from which we will get the energy, and when the cells are not going to get energy, they will not function properly. So most of the body functions are not performing because of the deficiency of ATPs, because of the deficiency of the mitochondrial dysfunctioning. That is actually called Lee syndrome. In Lee syndrome, it usually happening in the babies. But it's okay for your exam point of view. Also, don't worry about this Lee syndrome, but just memorize this Wernicke's encephalopathy, and of course the symptoms of dry and wet beriberi. And always remember, this beriberi is all because of deficiency of thiamine. The another name is vitamin B1. That's important for exam point of view. So here the question says, a 3-month-old breastfed girl becomes anorexic and develops generalized edema. So generalized edema, whenever it says generalized edema, we will always think about protein deficiency, because whenever it's localized to limbs only or gravity assisted, we will always think about congestive heart failure. We will always think about something related to heart. But whenever it says generalized edema or particularly periorbital edema, always think about protein deficiency or some related to kidney dysfunctioning with some degree of aphonia. Now, the infant is diagnosed with infantile beriberi. Now we have the diagnosis in our hand. Now, what the question is asking, what vitamin deficiency does this infant? So it's a very clear question. You know the diagnosis, infantile beriberi. So which one is deficient? Thiamine. So if it's mentioned thiamine or if it's mentioned vitamin B1, you have to choose that one. For this one, we have to go for the theory first. Infantile botulism. For this one, let me take you to emboss again. So of course, in infant, especially, we are talking about this botulism. That's botulism is actually caused by the ingestion of spores. The baby has to ingest spores, and spores may be present in honey, juice, and contaminated soil. So these are special spores, and germination of the spores in its intestinal tract cause synthesis of botulinum toxin. So that toxin is actually going to produce with the help of the spores, and this spores, we can see a mature immune system destroys coma, of course. So if the system, because why it's very common in infant, which is showing infant botulism, because in infant the immune system is not very much developed. Otherwise, in normal condition, these spores which are responsible for botulinum toxin, these spores are usually get destroyed by our immune system. But because in infants the immune system is not, it's just started working, it's not very much well developed. That's why these infants cannot overcome or get over these spores, and these spores can go into the GI and can proliferate and can produce botulinum toxin. So that's a toxin is excreted from these spores. So incubation time period, days to 4 weeks, maybe. It will take at least 1 month to develop fully symptoms. And from where the baby get this infection? The baby get this infection from contaminated soil, maybe those who are eating soil. So we have to have a clear eye on the babies. They should not eat any kind of thing from the floor, especially the soil. And sometime in honey and juices also we will have this spores. So that's the normal thing. We should not, we should not let the baby eat this raw juices and raw honeys, especially, that kind of honey which we usually give soon after the birth of the baby. That is also very dangerous to the baby as far as the GI system is concerned. So clinical features, infant may present with infantile hypotonia. See, floppy infant syndrome, just like a floppy baby. Floppy baby, what do we mean by that one? Where all the motor tones is very low. Like all the muscles, they are very less contractile. The baby is floppy. The baby is just like, just present like hypotonus. There will be no tone in the muscles of the baby. So there will be ptosis, especially ptosis, this drooling of this or dropping of this body part, especially we are talking about eyes, and most commonly used in reference to upper eyelid. So most of the time the eyelids are closed because of the dropping of the eyelid. There is no tone, there is no contraction of the muscles, floppy movement, generalized weakness is there, and of course the baby sucking will be very low, because the sucking is all about the motor activity, and here we are talking about the motor activity is severely affected. There is no tone in the muscles are not contracted at all. So,
excuse me, Dr. Hira, botulism is equal to adults tetany?
Yes, exactly. Where we can find the infection of tetanus infection. Yes. But here
is different. In the adults, there will be hypertonia and haze hypotonia.
Yes, and we have to think about that if we are talking about this one, then it's actually one of the bacteria who is actually forming this one, and that is Clostridium botulinum toxin. So maybe bacteria, and sometimes there are some protozoal infection that also produce this botulinum toxin. Some toxin which is just related to botulinum we can find in protozoal infection as well, but most of the time is a bacterial infection. If you're considering the adult one, that's a bacterial infection. Yes, but in children, some protozoal infection can also produce this botulinum toxin. So that's why spores word is mentioned.
In adult, there is bacteria. In children?
In children, of course there may be bacterial, but sometimes there are protozoal as well, which are releasing just like a botulinum toxin.
Protozoa.
Sometimes, yeah.
Which protozoa?
Any protozoal infection. We don't have any particular name like the one which we have very common, amoeba, but any protozoal infection, because once it's mentioned spores, think about protozoal infection. That's just how you can just memorize this one. But most of the time it's Clostridium. It's Clostridium botulinum. That's a bacteria.
Okay, thank you.
So if we just have a look at this one, again, infant botulism, we just summarized this one. That's a spore of this bacteria found in soil or contaminated honey. Constipation can be a presenting sign. So baby can present with constipation. Baby can present with descending palsy. Hypotonia is the most important one we just covered. Poor feeding will be there. Respiratory compromise can be there. So what you are going to treat, what you are going to go for the treatment, you will just give supportive care. Whatever the symptoms are there, just need to minimize the symptoms. And IV human botulism immunoglobulin. So that's one of the immunoglobulin we can give from outside, and that immunoglobulin is going to act against this botulinum toxin and can cause antigen antibody reaction and can destroy this the spores of this toxin. So maybe we can give immunoglobulin, but first always remember we can give supportive therapy. So if we look at the question here, a 4-month-old child present to the pediatric outpatient clinic with a 2-day history of constipation. So just think about the symptoms. Constipation is there, lethargy is there, fever is there. So it's an infection. The child was born to a 25-year-old primary catheter and is being breastfed. On examination, the child has flattened facies. So flattened facies means it's a floppy child, hypotonic child. And inability to smile or gaze away. Of course, why the baby is unable to smile? Because there is no tone in the muscle. There is no contraction. The contraction thing is not happening in the facial muscles. When a light is shined directly in the eye, you can see there is no contraction. There is no constriction of the iris muscle as well. Blood pressure is okay. Heart rate is okay. For 4 months, heart rate is okay. Temperature is high. Of course, infection is there. So it's most likely a bacterial Clostridium botulinum infection. Which of the following is the most likely diagnosis? So based on the presentation, so do you think what is this one? It's a botulism toxin based on the history of constipation, lethargy, fever, and this flattened facies that is all showing hypotonia. So hypotonia in just a 4-month-old child. So of course, it's one of the infantile botulism. If it's mentioned something here that like the use of honey or something, you know, especially the use of honey, so that will also give you a direct clue that this patient must be having botulism. But it's okay if honey intake is not there, but rest all the symptoms are there. So you can easily make a diagnosis of infantile botulism.
Hira, protozoa and amoeba are the same?
Amoeba is one of the protozoa that usually present with dysentery. The patient must be having mucus diarrhea. That's a clear, okay. That's a clear indication.
I said amoeba is the protozoa. Okay.
Protozoa. Yeah, amoeba is the protozoa. Okay. For this one, we have to go for the theory first. So next we have this giardiasis. Again, it's not there in MTB. Giardiasis, and then we have iron. The 2 topics are remaining. We'll cover quickly. So in giardiasis, again, this is one of the parasitic infection. Giardia lamblia is a parasite. So this is a parasitic infection by the protozoan. So again, this parasite is one of the protozoa infection. This transmission usually occurs by the fecal oral route. So if hand washing is not there properly, then or contaminated drinking water, the patient may get this giardia infection. And what is actually happening here? When traveling or living in endemic areas, so those areas who are very endemic related to this giardia infection, if someone is going to travel in that area, that may commit this giardiasis. Following the ingestion of this individual may experience abdominal cramps. So once the giardia is there in the body, it can cause cramping, it can cause frothy, greasy diarrhea. So whenever it's mentioned greasy diarrhea, abdominal cramps in the endemic areas, unhygienic history is there. Think about giardiasis. Diagnosis of giardiasis involves analyzing stool. So you have to go for the stool cultures and you will see exactly trophozoites. That's the precursor of protozoal infection. If you can appreciate trophozoites, so that's the confirmation of giardia. So most likely the clinical features we will see here. You will see diarrhea, foul smelling diarrhea, fatty stools can be there in that diarrhea, excessive gas, the floating, bloating can be there. The patient may be fatigued, and some of the time the patient may be asymptomatic. It's not going to show anything, but most of the time foul smelling diarrhea is associated with giardiasis. How you're going to diagnose your patient? You will go for the stool analysis, stool DR, and you will see exactly trophozoites. If trophozoites are there, then the giardiasis will be confirmed. Then we have immunosen, gastroduodenoscopy, and PCR, but these are very, you know, no need. If on stool analysis you can easily appreciate trophozoite, so you don't need anything else. For the treatment part, of course, it's a protozoal infection. You will give gram-negative cover. You can go for metronidazole, tinidazole. Sometimes you can give, but mostly we are using metronidazole. Alternatively, you can use any albendazole or mebendazole that is used for the parasitic infection, just for the infection like tapeworm or earthworm infection or any kind of hookworm infection. So we can give any antiparasitic medication, but most of the time this gram-negative cover is sufficient. Look at the question here. A 4-year-old girl is brought to the clinic for prolonged diarrhea. On examination, she looks pale. She is drinking 3 pints of goat milk per day and a very fussy eater. So she is taking goat milk a lot, three bottles per day. Test results show hemoglobin count is low, very low. MCV is okay. MCHC is a little higher side, but hemoglobin count is very low. Of course, the children who are using this goat milk and the cow milk, they're deficient in iron. That is for sure, because cow milk and this goat milk is severely deficient in iron. So these babies are usually developing iron deficiency anemia. That's why we usually give them iron drops. So which of the following is the most significant in the past medical history? So what do you think this patient must be having in the history? If she's having a history of prolonged diarrhea, so this prolonged diarrhea can be because of the intake of this goat milk, right? So we can think about, do you think it's because of hypothyroidism or aplastic anemia or psychological deprivation or Giardia parasitic infection? So of course, this is one of the parasitic infection, because the baby has a history of prolonged diarrhea. So if diarrhea is there, and she's a very fussy eater, and she used to drink this milk a lot. So maybe if this is not a pasteurized milk, not properly boiled milk, then what will happen? She can commit Giardia infection. And this hemoglobin count is low. This is only a distractor for you, because whenever the baby is on cows or goat milk formula that is deficient in iron, the baby must be presenting with iron deficiency anemia. Okay, for the next one, we have to go for the theory first. Iron poisoning, again, we will see in ambers. So here, iron overload. So whenever there is iron overload, too much excessive iron in our body, you will always see black things like black stools. If the vomiting is there, the vomit is also black. So that will give you a clue the baby is having, or the patient is having this iron overload. There will be too much of iron inside the body. So how we are going to describe it into two. If there is acute iron poisoning or chronic iron poisoning. Acute iron poisoning means that toxicity is common in pediatric age. Say for example, they have just taken all the iron supplements of their mothers. So that's a accidental intake. So that will of course cause acute iron poisoning. So how the baby is going to present if she is or he's having acute iron poisoning? Initially hemorrhagic gastroenteritis, possibly the shock can be there. Abdominal pain, vomiting can be there. You will see black vomiters, you will see black stools. Renal and liver failure can be there. See, it's too much threatening. And GI scarring and structure formation, sometimes if it's late, it can cause intestinal obstruction as well. So this is the thing, why it is happening. The baby has suddenly or accidentally taken all the iron supplements of their parents. Diagnostic point of view, you will check the anion gap and you will see metabolic acidosis. Because of the increased amount of iron, the body will show acidosis. So if on ABGs you find acidosis, abdominal X-ray, you can show radio opaque iron tablets may be visible. Of course, a baby, if you do the ultrasound, if you do the X-ray especially, you can easily appreciate that whatever iron supplements they have taken, you can trace the traces of those supplements. So that will give you a clue. For the management point of view, of course, we will give, very important, just memorize this one, deferoxamine. That's the only antidote we can give for the iron. So we can do this chelation, the deferoxamine. We can go for the gastric lavage, but if the patient presents to you within 30 minutes to 2 hours, then only you can go for the gastric lavage. If it's more than 2 hours, then gastric lavage will not give you any diagnostic value, cannot add any value to the patient, because after 2 weeks, all the stomach content must have gone through the duodenum, so it will not give any benefit to the patient. For the chronic iron poisoning, most commonly occur in the patient with primary or secondary transfusion and sickle cell anemia. So most of the time, when the patient is a known case of sickle cell disease or thalassemia patient, and those patients, those who are receiving blood therapy, they are receiving Paxil transfusion, they can also have a chance of getting this iron poisoning. So if they are presenting, they will present with hepatomegaly, cirrhosis. They can also have in the combination diabetes, skin hyperpigmentation, bronze skin will be there. It will take time for the skin to become bronzed, and hypogonadism, erectile dysfunction, arthralgia, cardiomyopathy. So these are all the related things which can be there because of the iron overload in the body. And this is not happening in a day or two. It's a prolonged process. It's a chronic thing. It will happen in days or in weeks or in years, because thalassemia patient, they need to get blood every twice a week or thrice a week. So think about in those patients who are the chronic receiver of blood, or the chronic receiver of Paxil transfusion, in which they can have too much amount of iron in the blood, and that can accumulate and can cause symptoms. So for the diagnostic point of view, we can see the liver enzymes can be raised here, and further diagnosis when the suspected underlying disease. So whatever the disease is there, or of course symptomatic treatment and symptomatic diagnosis will be there. So what you will do in these patients, like the hemophilia or thalassemia patients which receive blood actually, so we can go for the phlebotomy. If too much iron is there, you have transfused too much, you have to take out, you must have to take out all the blood. So phlebotomy you have to perform, like you are going to drain the blood, especially drain the blood through veins. Chelation again with deferoxamine. So deferoxamine is iron antidote. You can give this iron antidote deferoxamine, or you can just remove the blood. Only in the case of phlebotomy, only in the case of chronic iron poisoning, not in the acute one. So looking at the questions. Here it's saying a 5-year-old child presents with drowsiness, abdominal pain, nausea, bloody diarrhea after ingesting an unknown number of iron tablets. So now it's clearly mentioned unknown number of, but they are the iron tablets. The parent actually didn't know that whether he has taken the whole bottle or half of the bottle or whatever, but he has taken some iron thing. And you can see, once you do the result, you can check the iron, it's showing 94. So normal amount is up to 21.5 picomole per liter. But if the blood is showing 94, it means too much iron is there. What you're going to do, you will give iron antidote. And iron antidote is deferoxamine. Always remember, whenever it comes to antidote of iron, it's deferoxamine. A child is brought to the emergency department after accidentally consuming a large dose of nutritional supplements 2 hours before. Now he developed nausea, vomiting, abdominal pain, diarrhea. The vomitus is black. So if the vomitus is black and there's a history of nutritional supplement, that must be iron supplement. That's why the vomitus is black. The vomitus is black, the stools are black. Always think about iron overload. The blood pressure is, of course, it's okay on the lower, slightly lower side. Which of the following is the most likely diagnosis? Of course, based on the vomitus color, based on the history of nutritional supplement intake. So we'll always go for iron poisoning. Okay, so that's all for today. There's one marasmus, one question is there which is left. So maybe inshallah tomorrow we will cover that one. Okay, thank you so much, everyone.